Good day. On behalf of SIS Canto, I'm here to talk about middle meningeal artery embolization for chronic subdural hematoma. So, middle meningeal artery embolization is a minimally invasive procedure that involves blocking the damaged part of the middle meningeal artery. A chronic subdural hematoma is a type of bleeding that occurs between the brain and the thin layer of tissue that surrounds it, called the dura mater. This bleeding can occur after a head injury, but it also can happen spontaneously in older adults, especially those with a history of head trauma or who take medications that increase the risk of bleeding. These are some of the predisposing factors in the occurrence of chronic subdural hematoma. The dominant theory revolves around rupture of bridging veins, traversing from the brain to draining dural sinuses within the subdural space, but there are several characteristics of chronic subdural hematoma that argue for a more complex process as listed. Hemorrhage leads to proliferation of dural border cells. Influx of inflammatory cells to the injured dural border cell layer promotes proliferation of the cells into forming new membranes that are fragile and leads to rehemorrhage. Membranes frequently seen within the hematoma as well as in its inner surface are composed of border zone cells and proliferating fragile inner layer vessels that are prone to rebleeding. So the notion of subdural hematoma resulting from repetitive indolent inner layer hemorrhage naturally suggests embolization as a management strategy. So this is an example of temporal evolution of subdural hematoma from subacute to chronic stage. The diagnosis should be considered in an elderly patient with an altered mental status or new neurological deficit. There are several treatment options for chronic subdural hematoma, which depends on the current clinical status of the patient. These are some of the indications that may warrant middle meningeal artery embolization. Middle meningeal artery embolization is generally considered to be a safe and effective treatment option for chronic subdural hematoma. However, there are some contraindications for the procedure. This study shows comparison with historical control patients treated only with surgery revealed MMA embolization outperformed surgical drainage. The treatment failure rate during the 6-month follow-up in the embolization group was significantly lower than in the conventional treatment group. This table illustrates major published case series. However, the use of MMA embolization is lacking, with the majority of literature consisting of case reports or small case series. As the interest for middle meningeal artery embolization grows, more published studies have been documented, and there are ongoing clinical trials using different embolic agents to establish and further validate the effectiveness and safety of middle meningeal artery embolization. This is an example of a proposed treatment algorithm for chronic subdural hematoma, and this may vary per health institution. MMA is a branch of the maxillary artery, which itself is derived from the external carotid artery. It enters the skull through the foramen spinosum, courses through the dura, and divides into frontal and parietal branches. This lateral DSA with injection of the distal external carotid artery demonstrating an important variant of ophthalmic artery origin from the frontal branch of the middle meningeal artery and surrounds the optic nerve. This is a critical variant as the more distal central retinal artery represents a true end artery, and inadvertent embolization during a distal internal maxillary artery embolization with this variant results to blindness. This table lists some of the potential benefits and risks of middle meningeal artery embolization. In neurointervention, we use catheters, microcatheters, and their corresponding guide wires, microwires, to access the middle meningeal artery. We use different types of embolic agents to include the middle meningeal artery, depending on their availability as well as experience of the interventionist. For the cases, this patient presented with headache and was noted to have subdural hematoma along the right cerebral convexity. The main meningeal branches are variably named for the territories they supply. the frontal, parietal, and petrosquamosal or anterior and posterior branches. Further magnification of the angiogram shows cotton wool-like staining or blushing of the distal vasculature. DSA shows glue injection flowing into the frontal and posterior branches of the right middle meningeal artery, and glue cast is evident post-embolization. These are the CT scans comparing subdural hematoma along the right cerebral convexity. Oh, sorry, it's not playing, but it shows interval resolution. The next case also presented with headache and noted to have subdural hematoma along the left cerebral convexity, and lateral DSA shows the tip of the microwire within the frontal branch of the left middle meningeal artery. The safest policy is not to embolize from a position proximal or near the foramen spinosum to avoid embolization of the petrosal branch, which supplies the facial nerve, and avoid embolization of possible orbital anastomosis with the middle meningeal artery. And the last case is an example also presented with headache. Aside from bilateral subdural hematomas, and there's a frontal parasagittal vascular malformation on MRI. The right internal carotid artery DSA frontal projection shows the AVM.
The technical team will review the video clip later on. You just present the imaging first, and then they
Yeah.
will support to revise the video clip.
Anyway, this DSA is supposed to show the contralateral left side internal carotid artery DSA, because there's a left ophthalmic artery supplying the anterior division of the left middle meningeal artery. So if we continue with superselective embolization, we should keep in mind the different kind of anastomosis. So we proceeded with selective embolization, first accessing the anterior cerebral artery branches supplying the AVM. And another branch of the right anterior cerebral artery was selected to further decrease the vascular supply of the AVM. Subsequently, the frontal terminal branch of the right middle meningeal artery was embolized. The parietal or posterior terminal branches of the right middle meningeal artery was embolized as well. So note the cotton wool-like contrast staining prior to embolization. Since this case is a bilateral cerebral bilateral cerebral subdural hematoma, selective embolization of the left medial meningeal artery, frontal and parietal branches was done. Also note the cotton wool-like contrast appearance of the distal branches prior to glue embolization. Comparison of pre and post embolization of the right anterior cerebral artery branches and bilateral medial meningeal artery branches shows significant reduction of vascular supply to the AVM, and this will be supplemented by gamma knife radiosurgery 1 month after embolization. As we see in these sample cases discussed with the pathophysiology of chronic subdural hematoma and studies supporting medial meningeal artery embolization, this procedure is safe and effective as long as we know the etiology, aware of the vascular anatomy and possible variants, prepared and experienced with the right catheters and embolic agents for the procedure, and optimistic of the outcomes and willing to work as a multidisciplinary team. Thank you.